Kia ora tātou, and welcome to another Mobile Health Lunchtime webinar. You've got a great topic today and a great presenter, communication difficulties with adults, and your presenter is Sachi SUMMERLEE. So I'd like to introduce Sachi. She's a speech-language therapist working at the Christchurch Health Campus. Her areas of interest include communication and swallowing disorders in stroke and instrumental assessment of swallowing. She has experience working with adults across acute and rehabilitation hospital settings. Sachi is passionate about ensuring all people experiencing communication disorders get timely assessment, intervention, and ongoing support. And today her topic is going to include speech-language therapy role, causes of communication disorders, dysarthria, aphasia, apraxia of speech, and communication strategies. So welcome, Sachi, and thank you for joining us today.
Wonderful. Thank you, Pauline. Thank you for that lovely introduction. Kia ora, everybody. So as Pauline said, my name's Sachi. I'm really thrilled to be presenting to you today. So thank you so much for making the time and registering. So as Pauline said, I'm going to talk about communication disorders in adults, which is a topic I'm very passionate about. Okay, so first of all, I'd just like to speak quickly about the SLT role, and this may be something you're well aware of, depending on whether or not you've worked with speech-language therapists before. But we provide informal and formal assessment. We then provide diagnosis and any treatment that's indicated. A big part of our role is the provision of education for patients, their family, whānau, and staff who are working with that patient. And we also provide strategies to help to facilitate communication, and that's a huge part of our job. Great. So I wanted to speak about some of the main causes of communication disorders in adults. The most common causes are stroke, which is probably familiar to a lot of you, Parkinson's disease, dementia, head injuries, among a whole lot of other causes, brain tumours, hydrocephalus, motor neuron disease, mental health conditions, all kinds of things can result in a communication disorder. But it's good for us to be aware that the brain is remarkably adaptable, and even in older people, so even when people develop these disorders, there's a lot of hope and a lot of room for improvement. Lovely. So I'd like you to just spend a couple of moments having a look at this slide. Down the left-hand side of the slide, we've got a range of different diagnoses for communication disorders, and on the right-hand side, we have some definitions. And I'd just like you to take a quick moment to have a bit of a look and see whether any of those terms sound familiar to you. This is just kind of an exercise in your own head or with those that you might be sitting with while you're tuning in. And then as we go through the presentation, you might have your suspicions confirmed as we kind of define the different disorders. Or there might be a couple that you're not so sure about as well. There are a couple of terms that get mixed up a fair bit as well on the wards in the hospital and other settings. Okay, hopefully you've had a moment to look at that, and we'll go on. Great. So we're going to start with dysarthria, most commonly described as slurred speech. It's actually a group of motor speech disorders with a lot of different subtypes, and it affects one or many of the subsystems of speech. So it can affect your breathing, voicing, articulation, your resonance, and your prosody, so your melody of speech. And it occurs from damage to the central nervous system or the peripheral nervous system. As I mentioned before, there are many different types of dysarthria, and the different type depends on where the damage has occurred, and they can be sort of characterised by weakness, spasticity, or incoordination. Parkinson's disease is a big cause of dysarthria, and if you've worked with patients with Parkinson's disease, I'm sure you've come across hypokinetic dysarthria, and that's really characterised by quite a mono pitch, reduced loudness, variable speech rate. People's speech can the pace can pick up, be quite fast and very, very quiet as well. And that in turn affects somebody's intelligibility, your ability to understand them. So dysarthria, I wanted to get a bit of a sense of what it feels like for our patients with dysarthria. People often describe feeling tired of repeating themselves. People will say that they've been out and about and someone will think that they're drunk or they're on drugs because of the way that their speech sounds, which is a really challenging thing for people. And also just feeling like it's a huge effort to talk. When we haven't got dysarthria or another communication impairment, talking is such a natural, automatic thing to do, which doesn't take much effort at all. But with a communication disorder, it really changes that. Okay, so moving on to aphasia, you also might have heard it defined as dysphasia. We tend to, as speech language therapists, we tend to try to just use the one term, so we stick to aphasia or aphasia. The reason we do that is because it's easier for our patients with aphasia to just have one term to focus on, and the National Association is named aphasia, so we do like to spread the word to just use that one word if we can. So aphasia is a disorder of language processing, and it usually occurs because of damage to the language area of the brain, most commonly caused by stroke, and it affects your ability to comprehend and express language. Sometimes you may just have problems with your comprehension or just with your expression, and sometimes it's a real combination of the two. So it can affect all modalities of communication. So your talking, your ability to understand spoken language. It affects your reading, your writing, your naming, and even at a more severe level, it can affect your ability to gesture. Aphasia is the most prevalent adult language problem. And natural recovery after a stroke, we're very grateful for that, and it can be really important to reduce the effects of aphasia. SLT intervention has been proven to be effective as well, which is great, so we're doing something right. So, labelling the aphasia. There are a whole lot of different subtypes of aphasia, and the traditional terminology goes by neuroanatomy, so the different areas of the brain that might have been affected. It helps us when we know where the stroke or the brain damage was. It really helps us to identify the potential problems that somebody might have. But day to day, it tends to be more useful for us to use descriptors to kind of describe the problems that the person is having, rather than calling it a Broca's aphasia or a Wernicke's aphasia, which doesn't tend to mean so much to the person or their family. Okay, again, and a couple of really interesting quotes here, and these come from the Aphasia organisation website. So somebody said, it can be really frustrating knowing exactly what I want to say and just not being able to get my brain to give me the words I want. And you can see that the second half of that quote is in capitals, so very emphatic. The other person has said, communication allows people to know me, so struggling can affect how people see me and treat me, and also how I feel about myself. So we really can't underestimate how this feels for people. We all know that communication is sort of how we get our personality across. It's how we share our knowledge, how we are able to talk about the great things that happen in our day or complain about something. So really, really difficult for people when their communication is interrupted like that. Okay, so understandably, that can be a real emotional response to aphasia. People can feel a bit like they've lost their identity when you're unable to do those things that I was mentioning before. It can really impact on your relationships or your role, perhaps your job at work, the other roles that you have in terms of being a friend or a family member. People have a lot of concern about other people's perceptions, because people can wrongly assume that somebody has a cognitive impairment, that they're not thinking clearly, something like that, when really it's a pure language difficulty. And we really see that people's mood can change as their insight increases after a stroke. Sometimes people in the beginning phases can lack insight into the difficulties that they're having, and then over time, as they become more insightful, they realise the errors that they're making. People's mood can really change in response to that. Okay, but good news, there's a lot of hope for recovery for aphasia. And so another quote here from the Aphasia organisation. The good news is your brain can rewire and relearn. It takes a lot of work, a lot of practice, and a lot of patience, but I've trained my brain to use language again. It's taken a long time, 6 years, to get to write this with help, but I'm still training and my brain is still improving. So that's really an encouraging message. And you'll see there that person is still experiencing improvement 6 years down the track. We tend to see those really quick improvements that happen in the first few days in the acute phase and maybe the first few weeks in the subacute phase in hospital, but still people make great gains way down the track as well. Okay, so moving on to apraxia of speech. It's another motor speech disorder. And apraxia of speech involves difficulty planning your articulation. People can have difficulties initiating and sequencing and executing those speech sounds. It can affect your ability to select the sounds that you want and sequence them in the right order. Usually people are very aware of their difficulties. Sometimes in aphasia, people are less aware of the difficulties they're having. Apraxia of speech, people typically are aware of every mistake and feel very frustrated by that. Usually the errors are inconsistent, so you might ask somebody to say a word a few times in a row and each production of that word will be different. And it really often goes alongside aphasia, and particularly non-fluent aphasia, where you're sort of just saying one word at a time. Okay, so right hemisphere language disorder usually happens as a result of a stroke. And this one's very interesting because it can quite easily go undetected as a language disorder, and it's seen more as a change in personality. So people's pragmatics, the way they communicate, can be disturbed. People might present with reduced turn taking. They might just keep on talking and not pause for a break for you to respond. You might notice reduced eye contact and difficulty with emotional aspects of communication. People can have quite a flat affect and seem very sort of flat in their mood. Their voice might lack intonation that you would usually expect to express different emotions. People can also take things literally. So as part of an assessment, we might explain some kind of proverb and somebody will take that really, really literally. People can have difficulty understanding the cause and effect in situations, and that affects, people's safety at home as well, problem solving. They might come up with lots of irrelevant details. And these people with right hemisphere language disorder can often have quite reduced insight into the difficulties that they're having. And as you can see from some of the issues there, it can really impact on people's relationships too. I've got a poll question, Pauline, if it's enough to bring that up. I was just interested to know whether you think you might have come across anyone with right hemisphere language disorder before, especially thinking about people who might not... they may not have necessarily been diagnosed with that issue, but they might have had a stroke in the right side of their brain, and the way they communicate might just be sounding a little bit like what I've described. It's a real worry when people aren't diagnosed and treated for that as well, because, they might be missing out on some really helpful education for their family and therapy that could be provided by a speech language therapist.
Okay, can you see the results now?
Yes, thank you. Okay, well, that's really interesting. All right, so almost 70% of you think that you've probably come across someone with this disorder, which is really interesting. And perhaps, in some cases this has been diagnosed and they're receiving some education and maybe a bit of therapy, and in some cases maybe not. So that's really interesting to know, something to keep an eye out for. Sometimes it might take some time as well to be diagnosed and only become really obvious down the track. Thanks for that, Pauline. Great. So I'm going to move on now to talk about head injury in older adults. So as we know, as people get older, there's an increased risk of falls, and with that comes an increased risk of head injury. It's usually a closed head injury resulting in quite diffuse damage of the brain, and it can result in motor, sensory, behavioural problems and also cognitive and language impairments. Okay, so in these patients who've had a head injury, we see things like attention and concentration difficulties, so they might be able to focus for only a very short period, and that can come along with problems understanding what's been said to them as well. Memory and learning disturbances, word finding difficulties. People can have quite poor organisational skills in the way that they are expressing themselves. Perhaps they're speaking, but things are in quite an unusual order. You might see kind of unusual reactions to things and inappropriate swearing or laughing that person may not have done before their head injury. They might also have difficulties with turn taking and interrupt other people when they're speaking, and have problems maintaining a topic of conversation as well. That's a really common one. Okay, So we're flying through. Now, just a quick word about dementia. So there are a few early symptoms which can impact negatively on somebody's communication. They might have increasing difficulty managing complex tasks or new tasks. They might be withdrawing from their usual activities or showing a lack of their usual initiative. People might notice emotional or personality changes, and along with that comes some word finding and comprehension problems too. And I would say a great deal of you who are tuning in now have worked with people with dementia who have had communication and language impairments. Okay, so dysphonia is a voice disorder. And again, it's very common in Parkinson's disease. It sort of goes with that hypokinetic dysarthria. People will have hypophonia, so a very, very quiet voice, almost like a whisper. Presbyphonia describes an aging voice, and so a lot of people we see have a voice that can be so severely impacted that it's quite hard to understand the person. People can have damage to their vocal folds for a whole range of reasons. And when this occurs, we usually would recommend an ear, nose and throat assessment. That's really important to have a look at the vocal folds to see what the cause of the problem is. And as speech language therapists, once we know the cause of the problem, we can see people for some voice therapy, and we can also teach some vocal hygiene strategies to keep that person's voice as good as it can be. Okay, so we've quickly whisked through all of the kind of main communication disorders that we see in adults. So I'm going to move on now to hopefully the really useful stuff and talk about some communication strategies. Okay, so first of all, some general communication strategies. I think one of the key things, no matter where you're working and who you're working with, is a detailed case history, because when somebody's having a communication problem, context really helps. If you know the name of their daughter, who supports them, if you know where they usually work, if you've got that case history information, it's going to be incredibly helpful. Then when that person is able to express one word, and it might describe their job, you're going to have the context around it in order to be able to understand it and continue your interaction. Time and place is really important for communicating with someone with a communication disorder. Fatigue management is a huge thing, particularly in the acute and subacute phase, but even down the track as well. And it's really important to reduce distractions as much as you can. And I know that can be really challenging in a whole range of places where you might be working. For example, a hospital where there's a heck of a lot going on, a residential care facility where there's also a lot going on. But as much as we can, reducing distractions will make a big difference. I would always recommend communicating face-to-face, giving time and giving attention as much as you have. And a great idea is to establish the topic first. And that strategy works across the board for all the communication disorders we see in adults. If you are both on the same page in terms of your topic, then that's really, really going to help. And just covering one topic at a time. I often see people asking people who've come in with a stroke and they've got aphasia, and they'll ask them a really open-ended question. Like, what kinds of things did you do before you came into hospital? That's, a very open-ended question, and people might really struggle to answer that if they're having problems communicating. So as much as possible, kind of naturally cutting down the question so that you're giving somebody a couple of options. They might have the option to say yes or no, or pick from two different things. And then it may well mean that your interaction is going to take a little bit longer because you're sort of working through a few different options, but it's going to give somebody a lot more of a chance to get their message across than asking a big open-ended question. Okay, so now I'm going to get into some more specific communication strategies for different disorders. So for dysarthria, there are kind of some key strategies that will help most people with dysarthria. So typically we'll encourage people to slow down. So if you imagine, for example, they've got a flaccid dysarthria, their muscles of articulation are weak, the more quickly they speak, the harder it will be for those articulators to get into the position that they need to be in to make a clear sound. So slowing down gives a bit more time. We'll recommend people over-articulate, so sort of put a bit of extra oomph into the speech sounds. Concentrate on each syllable or sound. Also cutting down phrases and sort of saying a few words or a short phrase at a time with a pause, a big breath, and then continuing on. And we'll also recommend people think loud, and that's a big one for Parkinson's too. That's part of a Parkinson's treatment for dysarthria, where we're recommending somebody just really focus on thinking loud, and that can really help with their intelligibility. We can also ask the person to repeat themselves, and that can be done in a really gentle way that hopefully won't cause too much frustration for either communication partner, and to use other communication forms too. And we'll talk a little bit about those as we go, but basic things like writing down. If the person's really fatigued, you're really struggling to understand them, perhaps they can write a few words down. Great. Okay, so supported conversation is a really great sort of initiative, and it helps with the ability and the opportunity to engage in conversation. It's sort of, if you think a little bit like providing a ramp into a building for somebody who is using a wheelchair, it's the real focus is on communicative access. So the communication partner providing those ramps that are required for the person to get their message across. And I think that's a really important thing for us to think about. We think quite a lot about what physical aids somebody might need in order to be able to move around and do their daily activities, and we think a little bit less about what ramps or support we could be providing people who are having problems communicating. So the idea is to reduce communication breakdowns. So when you both kind of get stuck and you can't move on, and it relies a lot on the communication partner. So this whole idea is really teaching those who are communicating with people who have communication disorders to support them. Okay, so another big principle is to acknowledge competence, and I think this is absolutely huge for our patients, particularly with aphasia. And that can be as simple as using a phrase like, I know you know. I know that you know what you want to say, but I see that you're having difficulties expressing it. And that can be really, really affirming for somebody who's having language problems. So as well as acknowledging competence, we want to reveal competence, and that really takes the skill of the communication partner. And it's kind of focusing on what are the things that this person can do and how can we utilise them to make their communication the best we possibly can. So we're going to create and use those communication ramps and focus on total communication. So not just speaking, but using other available tools as well. Okay. So when we think about getting the message in, so I'm thinking about what I would like this person to understand from what I'm saying. So first of all, we're going to want to adapt the way that we talk. Really important as well that we still speak to people like the adults that they are. Adapting your talk doesn't need to make somebody feel like they're a child or that they've got a cognitive impairment. There are some really simple and natural ways that you can adapt the way you talk to help somebody to understand. So we can simplify what we'd like to say and use a slow but normal rate. Shorten our sentences a bit. So often, probably as I am today in this presentation, we're getting out a lot of words on one breath, and it's our turn to talk. We're going to say a few sentences at once. So it's really thinking about slowing yourself down and taking sort of one chunk at a time. Pausing often. Sticking on one topic, that's a really key one, that you've established the topic and that's where you're going to stay until you really clearly move on to the next topic. You're going to want to exaggerate the keywords. So, for example, you're talking about somebody having a shower. So you really want to make that word really obvious, and that might include writing it down as well. So the person's both hearing it and they're seeing it written down. At times it can be really good to just repeat what you've said or rephrase what you've said in another simple way. Give somebody time to process it first and then repeat it, and you're kind of just clarifying that they've definitely got your message. Sometimes people will panic a little bit. They'll say the first part of their message and then they're getting the sense that the person's not understanding. So they'll quickly rush out and rephrase it, and that can be really overwhelming for somebody. So it's just taking it slowly, checking in, making sure they've understood, repeating it in a simple way if necessary. All right, and we've also got to be really direct when we're communicating with somebody who's got problems understanding, which as Kiwis, we're not always very comfortable being direct. We can sort of beat around the bush a bit. So really think about being direct with your message. And if you happen to be in a group setting where there are a few people contributing to the conversation, just ensure that there's just one person speaking at a time. Okay, so a little bit, I sort of touched on this briefly before. We want to support what we're saying, and there are a few things that you can blend with your natural speech as needed. So gesture is a huge one. If you're talking about brushing your teeth, you can really naturally bring that into your instruction. You might say, right now, would you like to brush your teeth? And just do a simple gesture alongside that. Using facial expression as well. If you're talking about something exciting, use your facial expression. If it's something that perhaps is a bit more serious, have your facial expression match your message. Written keywords can be really huge. Just one word at a time written on a whiteboard, something as simple as a piece of paper, and that can really, really help to just as an adjunct to what you're saying. Drawing is also a really great one. You might be working with somebody who actually is unable to comprehend a written word, but a picture they recognise. So you might draw something for them instead. It doesn't have to be anything amazing. I'm certainly not an artist, but I do use drawing when I'm assessing people or providing therapy, and it can be really helpful. There might be particular resources that people have been provided by a speech language therapist, so use those as much as you possibly can. And another couple of really simple things, an object, for example, you might say to somebody, where's your key? And while you say it, just lift up a key at the same time, and that can really be the thing that helps to get the message in. I'm just going to have a quick sip of water. My voice is getting a bit tired. Okay, so focusing now on helping the person get the message out. A couple of things that are pretty similar to getting the message in. Again, establish your topic first and then narrow it down to the details. You might have a big topic. We're going to talk about, where your house is, and then we're going to narrow it down as we go. Give the person lots of time and really focus on the message that they're trying to get across. And verify, so reflect back what you think they've said to you. It doesn't matter if you're not sure, give it a bit of a go based on a couple of keywords you might have understood. Then you might be able to expand on it a little bit and provide a summary at the end so that that person can let you know if you've got the right story. Okay, so a couple of verbal strategies for helping to get the message out. And I mentioned these before, so asking yes or no questions. We do, although, have to be aware of some people who won't have a reliable yes or no response. Perhaps their auditory comprehension has been affected to a level where it's really difficult for them to understand the question and reliably say yes or no. But if you know that person is able to indicate yes or no, whether it's verbally or non-verbally, then that's a great strategy to use. And also giving forced choice options. So a really obvious one is, you might have someone around to your house and you say, do you want tea or coffee? They're your two options. So just breaking something down to two options, it gives that person a lot more of a chance of getting the message across than if you say, what would you like to drink? All right, some non-verbal strategies. Again, encouraging that person to gesture. Having written forced choices, so you might have two things written down for that person to point to if they're unable to verbalise it. Picture charts, technology. Obviously, there's a lot of great technology out there too. The use of iPads and apps, things like that. Typically, we suggest, especially in the acute phase, that people don't rush out and purchase a device or a particular app just until things settle down and they, it's really clear what they need and are going to benefit from. Okay, so some additional strategies for apraxia. You want to just ask for short, simple responses. If the patient is really struggling, they're really stuck on a word and they're attempting to correct it, really encourage that person to just stop, pause and rephrase. Sometimes the more somebody will attempt a word, the harder it can be. And encourage slow speech as well. That'll give a little bit more time for those speech sounds to be programmed and executed. If the person's really struggling with a particular word, you can suggest that the person just watches your face while you say it. That can be a really helpful cue. They watch you articulating it and they might be able to repeat it back to you. And then move on to the next part of the message. Something that's not helpful, though, is asking somebody with apraxia to repeat a really troublesome word, because each time they try to repeat it, the execution of it could be different, and that can be a really frustrating task. Okay, so some strategies specifically for right hemisphere language disorder or cognitive language impairment. Really good to involve family, whānau, friends, any of those close, important people to help the person to gain some insight into the differences that are present in their communication. And it's okay for us to gently but clearly point out any interactions that are inappropriate or tactless, not the right way to respond to a situation. We can also liaise with an occupational therapist for any visual changes and also sequencing tasks, because these two things will often really go hand in hand. And sometimes we need to set limits on speaking time. Somebody will be quite verbose and will have a lot of difficulty self-monitoring, knowing when to stop talking. So we can really gently sort of say, right, you've got a few minutes, and then we can pause there and it's going to be my turn to say something. And great to praise the person as well for appropriate ways of communicating and encourage, the ways that they might have communicated before their injury. All right. So again, along with those kind of memory and learning difficulties, it's really important that we repeat the information that we say, clarify it and write things down. I think that's a really key thing, because day to day it might be really difficult for that person to retain what you've said to them. So having something written down too is a really good idea. Okay, with our patients who have dementia, I think this is incredibly important, is using an alerting strategy. So using their name. If their name isn't such a great alerting strategy, just a really gentle touch. It's really good to try not to startle people and also to get people's attention to what you would like to communicate about. So you can use a description to help someone's understanding too. So, for example, phrasing something like, put this on to keep you warm, it's a cardigan. Kind of just wrapping some extra information about the thing that you're talking about to help the person understand, what it is and what it's for. And really nice as well to reinforce correct responses. So if somebody says, oh, yep, that's Mary, you can say, that's right, her name is Mary, and kind of affirm those things that people are getting right. Okay, so a quick word on frustration. This is a really huge thing for people with communication disorders and their communication partners in lots of instances as well. I think the main thing to know is that silence is okay, and it can feel really awkward, but it's a really important part of allowing somebody time to get their message across. I think also really good to acknowledge the frustration. If someone's clearly frustrated in front of you with their communication or with the way that you're responding, I think it's really good to just stop for a moment and say, look, I see you're feeling really frustrated. I understand why you're feeling that way. This is seeming really difficult for you. And I think that can mean a lot to people to sort of feel understood. Like I mentioned earlier, acknowledging competence, saying, I know that you know what you want to say. I know that you're thinking in the way that you normally would. For example, for somebody with aphasia who hasn't got a cognitive impairment, they've just got difficulties processing language. Just letting that person know that you understand they're really trying and that it's they've got that message in there. When appropriate, point out improvements. I think that can be really encouraging for people. You might see somebody one day, you see them again in a couple of weeks' time, and you can let them know, look, compared to when I saw you last, you've really improved. And I think that's hugely encouraging for people, especially when day to day they might not be noticing those little improvements that are occurring. If you're having interaction and you've just got no luck, you're both really, really stuck, you've tried some of those strategies that we've talked about, you notice the person's really tired, it's okay to say, look, should we park this here and we'll come back to it a little bit later. I realise there's something really important you want to tell me. Should we try this again later and see how that person feels about that? Sometimes you'll just get to a point where you can't go any further and you need to try again later. Okay, so there are some validated communication screening tools available for non-speech language therapists. They do require training, but they're out there. So if anyone's got any questions, do let me know. As the person who's, in any capacity, working with, caring for someone with a communication disorder, you can document any sudden changes in the person's communication. Rule out delirium. I think that's a really big one, especially in the acute hospital. We'll have patients come in with a delirium, and it presents quite a lot, in some cases like a cognitive language issue, like an aphasia. They've got word finding difficulties, but eventually it resolves and the person's communication goes back to normal. Also check for depression too. I think for our people who have communication disorders, unfortunately, people can be quite easily isolated. People can withdraw from their usual activities, the roles that they held before the injury to their brain. Suddenly they're not there anymore, and depression can creep in pretty easily. So really good to keep an eye on people's mood when you're working with them or caring for them. And it's always great to refer to a speech language therapist if you feel that you need any specific advice to assist with communication. As I said before, even well down the track, people can still be making improvements after an acquired communication disorder. So, don't rule it out if somebody is even a few years down the track. Okay, so just some of our intervention principles when we're working with somebody with a communication disorder. We always want to ensure all areas of that person. So the ICF is quite a good way of keeping all those areas in mind, but we want to make sure they're all covered when we're working with somebody. We want to think about the whole person, not just the person sort of in the hospital bed, but everything about them, their roles, their usual activities, all those sorts of things. We'll give direct therapy, and we always want to make sure our therapy is really tailored to that person, because if we bring along some therapy resources that are based on cars, for example, and that person has absolutely no interest in cars, then that therapy isn't going to be meaningful for them. So a really targeted approach with things that are meaningful for the person are the way that we like to do our therapy. Giving compensatory strategies, obviously, to help that person to compensate in the meantime while they're recovering, or perhaps in the longer term if they need to. Counselling and training communication partners is a big part of our job. So giving verbal education, helping people kind of come to terms with the shock of the change in their family member, their friends' communication is a really big thing, and that can often go over days and weeks and well down the track. We always want to encourage effectiveness over accuracy. So our main aim is for somebody to be able to get their message across and for them to understand their communication partner's message, for them to be able to have meaningful interactions. That's way more important than making sure you've got 100% accuracy in your naming or your articulation of a word. Effectiveness over accuracy always. And we are always encouraging persistence as well for that person to keep on working, because there's a lot of hope to recover. Okay, I actually think this might be my last slide. And I've probably finished a little bit early, sorry, but hopefully we'll have a few questions to answer. Support networks are incredibly important for our people with communication disorders. So friendship is really important, and it's good to bear in mind that that's the kind of thing that can be disrupted after somebody has a new communication problem. Really hard to maintain a friendship if that person doesn't know how to support you. Family and whānau, obviously incredibly important too, and the same things apply. And then groups. There are groups all around the country. Particularly, there are a lot of groups focused on aphasia. So people with aphasia getting together There are people who get out and fundraise. There are groups who cycle around the country. And those groups, you can see when they get together that peer support and encouragement is incredibly therapeutic for people. So groups are really great. There are choirs for people with acquired communication disorders and different conditions. So I would encourage you as well to sort of look into what might be available in your area that you might be able to refer the people who you work with to, so they can have that little bit of extra support. Okay, great. That's all my content. Thank you.
If you want to stop sharing your screen, it'll be easier for you to talk directly to people. I've got a few questions. First of all, a comment from somebody who says, my sister has MND, and I'm so amazed and grateful that she can message me on my mobile. And she says, thank you so much for all the work that you do.
Oh, that's so wonderful. I'm really moved to hear that, actually. It's just, I'm very passionate about it, and I think being able to maintain communication, it's a human right. It really is.
Absolutely.
Great to hear.
We have a question here from Jackie. She says, are prompt and picture cards helpful in patients with PPA? And can a private hospital refer to a community SLT for PPA strategies?
Oh, that's a really good question. So I'm guessing we're talking about primary progressive aphasia, if that person can correct me if I'm wrong.
PPA, that's probably what she means. Yeah.
Okay, great. So you asked if picture cards
are helpful for those patients?
Great, absolutely. Anything that's going to support that person's understanding is really, really helpful. So simple picture cards. Think about the pictures that you use. Some people respond better to a real photo. Some people respond better to something more simple, like a line drawing. So it's great to look at how the person responds to different kinds of pictures. And can a private hospital refer to a community SLT? Yes, there are different systems all around the country depending on the district health board, but I would at least give it a go, and often referrals can go through the person's GP. So hopefully you can find some speech language therapy input where you are.
Good, thank you. Somebody's asked for the slides. We often get that question, and no, webinars don't generate slides, but what we do, of course, is record it, and it will be on our website within a few days, and I've put the URL on the chat function for you to see there. I just wondered, so I'm just waiting for more questions to come in, but I was wondering, Sachi, do you have any examples of those communication ramps that you were talking about?
Oh, okay. So when I talk about communication ramps, there's sort of all of those strategies that I spoke about, those things that we can put in place to kind of bridge that little gap that the person might be experiencing to get their message across. So it might be us asking a yes and no question or a forced choice question rather than an open-ended question that would act as like that little ramp for that person that kind of helps them to understand what you're saying. Yeah.
And since we've got a bit of extra time, I was wondering if you wanted to say anything more about those validation tools.
Oh, yes. Okay, so there are a couple of screens. There's one in particular that I'm aware of that's used at Christchurch Hospital, and that's actually used by our trained stroke nurses who go around and see any person in the hospital who's had a suspected or a confirmed acute stroke. So they use a tool called the LAST. It's actually it was written by a French speech language therapist. It's validated. It's very, very quick. It is in English, in case you're wondering, so we can easily use it here in New Zealand. It takes about 90 seconds to administer, and it just looks at really basic auditory verbal comprehension, so understanding of what's being said, and verbal expression. It doesn't look into reading or writing, but it can be a really helpful little screening tool, and anybody can use it.
How do you spell that?
Just LAST in capitals, yeah. I think it stands for something like language screening tool.
Yeah. Cool. Thank you very much. Good. Well, I think you model beautifully clear speech and taking your time. I know it's your bread and butter, but I just recognise how hard it is when people are under time pressure to probably match your modelling, but you do it beautifully. I don't have any more questions. I'm just wondering also, though, do you know anything about the accessibility? If somebody wants to access a speech-language therapist in a rural area, how many of you are there, and how easy is that for our rural health professionals?
Yes, that's a really good question. And I think, as with lots of health services, it can be easier speech therapists can be easier to access in a larger centre. But, for example, in Canterbury, there are community speech therapists who go right up to Kaikoura and down towards Ashburton and inland a little bit. And I would say around the country, each DHB would have a similar kind of a resource where community speech therapists will go out from the main centre and see people further afield. There's also a lot now of Zoom therapy, obviously, which would have got even more popular during lockdown last year. Yeah. So that's a great option too. I mean, as we can see, we've had a really good connection today. So you can imagine having a great conversation and doing therapy or assessment over Zoom. So that might be something to look into as well if you're a little bit further afield.
Very good, very good. Well, I won't spin it out any longer. It's been very, very interesting. And, hang on. As I say that, one question is coming. It might just be, I have a client who uses a Megabee board and an eye gaze tool as a bridge.
Great. That is really, really great. Those tools are used here at Christchurch Hospital quite often in the intensive care unit or the spinal unit over at Burwood Hospital. Those are really, really wonderful tools for people.
What are they? Tell us.
Those tools are for people who, perhaps they're unable to use any voice, and they might use eye gaze or sort of like a partner-assisted scanning kind of thing where you've got somebody across the other side of the tool. So the Megabee is sort of like quite a large kind of plastic thing which you can hold up. I mean, it doesn't look super high-tech, but it's incredibly effective for those people who it works for. I think it's good to know for those tools that usually it's really helpful for a speech-language therapist to have been the one to come and do an assessment and make sure it's helpful. Sometimes introducing a tool that hasn't been specifically assessed can be more frustrating for somebody if it's not successful. But there are some great tools out there.
Good idea. Is it common for people with dysarthria to keep saying no but mean yes, or vice versa?
Oh, that's a really good question. And actually that sounds more characteristic of aphasia, the language problem. So perhaps they're having problems understanding the question, so then saying yes instead of no, or vice versa. Or they might be somebody who gets stuck on a particular word. We'll have people who, we call it perseveration, where the same word keeps on coming out. Incredibly frustrating for that person. So they might want to say yes, but they're stuck on no, and they'll respond no to questions. So rather than dysarthria, which is more just how your speech sounds, that's part of aphasia, the language disorder. But that is a really common difficulty that people with aphasia have.
Mm-hmm. And can you recommend any written resources to give to family and friends?
Oh, yes, that's a really good question too. There is some really good written information from that website that I had up on one of my slides. So it's aphasia.org.nz. That's a great website, and you can request resources. So we get some sent here to Christchurch Hospital. They're really nice. They're what we call aphasia friendly. So they're laid out really nice and simply. So easier for somebody with aphasia to read, because we want that information to be accessible for people. And then you might also find your local district health board might have some kind of written information that you could find online to give out to patients. I know here at Christchurch Hospital we've got kind of some basic pamphlets and things that can be given to people.
Good. Excellent. All right. Well, look, your time is almost up now. It was worth waiting for those extra questions, wasn't it? So I'd like to thank you very much, Sachi. That's been a great presentation. And thank you, everybody, for joining us. Please. I'll say goodbye then and finish the meeting. Goodbye, everybody.
Bye-bye. Thank you. Thanks, Pauline.